Magnesium is critical to human function and is one of the most common cations present in the body. In this video, we will review the physiology of this essential mineral and the causes and management of hyper and hypomagnesemia. Magnesium is largely an intracellular ion and is a prominent cofactor in cellular phosphate metabolism. As a result, it has critical roles in energy production, protein synthesis, and nucleic acid generation. Total magnesium concentration in the plasma is maintained between 0.7 and 0.95 millimoles per litre. This constitutes less than 1% of total body magnesium stores. 60% is ionised, 30% is complexed with protein, and the remainder circulates complexed with various organic ions. Magnesium is measured in a variety of units. 1 millimole of magnesium ions is equivalent to 4 milligrams of magnesium. The major controller for magnesium concentration is via renal loss of excessive magnesium. In renal failure, excessive amounts of magnesium cannot be excreted and toxicity may result. Hypomagnesemia is defined as a serum level less than 0.7 millimoles per litre. In ICU, the most common causes are related to redistribution as a result of alkalosis, catecholamines, and other drugs, or due to magnesium loss associated with diuresis, diarrhea, or laxative abuse. It is more likely in malnourished and deconditioned patients. A number of drugs, including aminoglycosides, timentin, amphotericin and loop diuretics, are associated with renal magnesium loss. A number of drugs, including aminoglycosides, timentin, amphotericin and loop diuretics, are associated with renal magnesium loss. Magnesium replacement is commonly required in the general ICU population. Clinical features are uncommon and usually develop only at levels less than 0.5 millimoles per litre. Common manifestations include atrial fibrillation or torsade de pointes, weakness and various neurological disturbances, and resistant biochemical abnormalities such as hypokalemia and hypocalcemia. Type 1 renal tubular acidosis may also develop, and hypomagnesemia may exacerbate digoxin toxicity. Magnesium can be replaced orally or intravenously. A number of magnesium salts can be given orally, with varying magnesium concentrations. Magnesium aspartate, which is a common preparation, contains 37.5 milligrams, or almost 10 millimoles, of magnesium for every 500 milligram tablet. The bioavailability of oral magnesium is almost 100% and is good for long-term replacement of total body depletion. Magnesium sulfate is the most common IV preparation of magnesium. In adults, an initial dose of 10 millimoles, or approximately 2.5 grams, can be administered IV over 5 to 15 minutes. If given too quickly, it can be associated with hypotension, bradycardia, and nausea. Total body depletion of magnesium is common and requires additional doses, frequently up to 60 millimoles over 24 hours. Total body magnesium depletion may persist even when serum sodium levels reach the normal range. Magnesium retention in renal failure is common, so a more cautious approach and frequent blood sampling is required. This uncommon condition is usually well tolerated until levels exceed 3.0 millimoles per litre. The most common reasons are related to therapeutic administration of magnesium in patients with altered renal function. Acidosis may slightly increase levels due to the redistribution from intracellular stores. Hemolysis of a sample post-collection causes artificially high levels, as red blood cells contain 3 times the concentration of magnesium compared with serum. Toxic levels of magnesium may lead to areflexia, weakness, respiratory insufficiency, and widened QRS. Hypotension and nodal block may occur, and asystole may eventually result. The treatment of acute hypermagnesemia is to stop administration, facilitate removal via induced diuresis or by dialysis, and intravenous calcium, which acts as a physiological antagonist to combat the conduction deficits.